So the next speaker is Dr. Miriam Rosin, who is the director of the British Columbia Oral Prevention Program for the British Columbia Cancer Agency. And she'll be talking about the Canadian approach to oral leukoplakia from basic science to public health. Miriam.
Hi, everybody. So I just want to say right up front that this has been a lifelong passion for me to try to work to reduce this deadly disease, oral cancer prevention. And what I'm going to be talking about today is the work of a very large, growing number of people that are focused to a common vision. And I think that's what's driving the change inside of British Columbia. It's this shared vision. And I want to take this point now to say thank you to Eva for letting us talk about the vision in BC and talk about the incremental change that's happening. It's really a slow process, like Dr. Thun said. You have to keep at it. And we're going to talk about how it's rolling across BC, then going national and our international output. So, nothing to disclose, and here we are. So, why oral cancer? Okay? So, those of us that are working on this and working for large parts of our life on this study, I think are really focusing on this mixture of challenge and opportunity, right? So this is a disease of global consequence. There's 350,000 new cases each year, a lot of them in developing countries. It's a big problem with resources. High mortality rate, 30 to 60% 5-year survival rates. And yet we have knowledge of risk factors. It's tobacco, alcohol, and the new guy on the block, HPV, right? And from our standpoint of this lecture, it's a very accessible site. I mean, you can open the mouth, you can look, you can see the changes. You should be able to have impact. And that's, I think, the challenge and the opportunity that we all face. Even if it's accessible, we detect it late. It's spread. It has devastating effect on the patient, the loved ones, society in general. How do we change that? There's a need for change. So I'll be talking a lot about this screening and detection and how do we facilitate it. And here's really an interesting thing, because we've already shown, we have some evidence that detection, early detection of the disease, oral screening reduces mortality. And where does it come from? It's coming from India. So here, India is leading from the standpoint of detection. And so what they've shown in India, this is a paper from Sankara, it came out in Lancet 2005. It's a large study, 200,000 people, put into 2 arms, screening and non-screening, and they followed it for over 10 years, and a 34% reduction in mortality rate in the screen versus the non-screen group. So it's very exciting. A lot of people got excited when this paper came out, but how do you have global impact? How do you move forward on this data? And really, and what I'm talking about today is how do we move forward in North America or in those places where the disease is less prevalent? And so here we're talking about opportunities. And in British Columbia, we identified over a decade ago that we had an opportunity with our dental networks. There's a group of people that look inside the mouth of people every 6 to 12 months, and there's an opportunity for detection. How do we facilitate that? What do we need? And that's the dialogue about today's lecture. So, can I move the slide, please? Thank you. Okay, so I'm going to ask you, last time you had a dental checkup, did you receive an oral cancer screening? Yes. Hands up. Not bad, hey? No, hands up. Some people don't know, hands up. Okay, that's very common, that a lot of times people are unaware of whether they've been screened or not. And this is really a big issue for us. And just some key things, if they put gauze around your tongue and they pull it out and they look underneath, or they palpate, they're probably doing an oral cancer screen. But you need to go back to your dentist and say, have I had an oral cancer screen? Because we want to enforce that behavior. So, here's the roadmap we're going to talk about today. Talk about the scope of the problem. If we're going to pull these dentists into a network and make use of this critical resource, how do we do it? And a system for thinking about it, and then the strategies that we put into place in British Columbia. Here's the scope of the problem. We started the program in about 1999, and at that point we looked around the province, and big problem. Activities not integrated. There's scattered activity. We had detection in the community dental practices. If you asked, a lot of the cancer patients had their disease identified by the dentist. And the good news was there was linkage to a centralized pathology service. Really good news, because that gave us some way of dialoguing with the dentist. But then after that, upstream, no standardized referral pathway, a lack of surveillance. We don't know what happened to the patients if anything was detected. And big barriers to patient flow. If you had a dysplasia identified, nobody took any kind of initiative of who did those patients belong to. And big problems with risk assessment and then the treatment of the disease, no consensus. And so this is where the researchers come to play. On one side, we've got the dentist detecting. On the other side, we've got the clinical system and the researchers to try to pull this together and talk about risk assessment. So a system for thinking about, and this is the fusion going between basic scientists and the technology development to answer questions on the management of the disease, integrating that with healthcare service, clinical care, all these professions that are involved in managing the disease, and then public and population health being really critical from the standpoint of surveillance and health promotion and prevention strategies. So about a year ago, we took everything we did and we put it on top of a health promotion model and looked at population health. And we decided, okay, well, this is our orientation to make change. We have 3 points. First thing we did is we have integrated knowledge translation, and actually this has been happening for the last decade. And what that meant is that we went to all the stakeholders and we dialogued. And we had a constant go back and forth with knowledge translation as every step that we go through the process. And social mobilization was really key. That means we basically activated as many people as we could inside the system. So networks, partnerships, institutions, we pulled as many as possible into the dialogue right up front and got them involved. And then the final thing that we've moved into more strongly now is this whole issue of social marketing and using it as a planning and interventional framework. And what that means really is that we listen. So we go to each of the stakeholder groups and we say, okay, what's the problem? What do you need? And then we look for creative ways of producing what they need. And so I'm going to talk about this as we go through the step-by-step process we went through. So first thing is taking advantage of what you've got. This is a big deal. And so when we started in 1999, we had this little cartoon, and we thought of, okay, we've got the province of BC, and we've got all these patients. We're filtering them down through the system. At one end, the whole province, and at the other end, we come up with the high-risk people, the people for treatment, and how do we put all that stuff, all that structure together? So we had the dentist looking at the patient twice a year, risk factors, clinical assessment, sees something, either biopsies or refers to somebody to have a biopsy, and those biopsies ending up in this central biopsy service. Problem, nothing happened. How do you do the linkage then, right? And so we had NIH and AACR come in and help us build infrastructure. And so we created risk assessment clinics, dysplasia clinics, where we would assess these patients coming forward, and they would be referred forward for treatment, and we'd follow them in treatment. And so we built a longitudinal study, and in that longitudinal study, we started engaging the scientists, and we looked to see, okay, what are the problems with patient flows, and can we build technology to facilitate the problems? And so we had this huge spectrum of things that were happening across the different disciplines in the different institutions. So these are the 3 I'm going to talk about today. One of them is we needed to empower the dental clinics. They needed to be ready. If the patients show up at the clinic, the dental profession, they needed to know what to do, right? So it's one of the big ones. And then we needed a surveillance system. We can't just do these things without actually asking what the impact is. So I'm going to talk about that. And the third thing really is this whole readiness on the side of the medical system to receive these patients and to treat them effectively. So I'll talk about each of these 3 things over the remaining time. So here's where we started. So we had a vision for change. We started with dental focus groups, the dentists, the hygienists, the CDAs, the dental administrators. We brought them together into groups, and we said, okay, share our vision. What do you need, right? And so we had a lot of dialogue, and they came up with a list of things that they needed in order to move forward. So this is the work of Denise Laurent and Michelle Williams, and this big team of individuals setting up this framework. So what did they say? Long list. But on the top of the list was, we need guidelines, we need protocols, we need a referral pathway. We need to know what to do with the patients, and we need increased awareness. And so we've worked on that with a lot of attention over the last several years. So here's the guidelines. The whole point of the thing is that you can't just ask people to participate, do these screening, if you don't have some kind of control on the system. And so we went to our College of Dental Surgeons of BC. This is the regulatory body. And we said, okay, we're sharing a vision. Would you work with us on this vision? We need guidelines. We need to provide these. And this is the first guidelines that the college had produced, and they produced them in partnership with us. So we were really proud of this, right? And so here we have step-by-step process. Step 1, step 2, step 3, step 4. You do this when you do the exam. You tell the patient what you're doing. You do this. And if you see this, it goes here. If you see this, it goes here. If you go this. And now we have everybody dancing the same dance. Okay? So this has been really powerful. And we've seen these guidelines. They were put out at the provincial meetings. They were published into our journal, the Canadian Journal Dentistry. And they've gone national, they've gone international, they've been translated into Spanish, they're being used by different countries, and this is really causing change. One thing is the open dialogue, but there's also a change in practice. So here's what's happening in British Columbia. This was a telephone survey that was done by the college. We've transferred ownership to the College of Dental Surgeons of BC, and we asked the question, okay, if those people, are you aware of the guidelines, or have you seen them? Have you used them? And what's the difference in their behavior? So here's people. This is the percent that are providing oral cancer screening. And you see it going up when people have seen the guideline. But this is more important here, the yellow bars, because we're asking, are you now doing oral cancer screening as part of your routine examination? And you see this now going up. So among dentists who have seen the guideline, 84% screen as part of the routine exam compared to 65% that are not aware of the guideline. We're trying to make that a regular, consistent practice with high-quality screening. So here's the next step. We have to keep the pressure on, right? And so we've now gone into knowledge social marketing strategies. And here we have Kitty Corbett, who's a social marketer, and we're doing a Postcard for Principles campaign. So for those of you who don't know what this means, it means that you ask for endorsement of a few principles. We go to the 12,000 people working in dentist industry in British Columbia, and we say, okay, here's a few principles. Screening should be part of routine universal practice. Do you agree? And if you agree, would you let us now use your name in press releases? And we get this list of names, and then we publish these things inside of the journals that say, here's the principles for screening, and all of these people agree. So you have these long lists of names that basically say, I'm in agreement to this principle. So what this does is it raises awareness of the oral cancer, and it changes perceived norms, which is really critical, fosters involvement, shared purpose, and it gives us a communication platform. Now we can go back and we can dialogue with these people. And this communication is crucial. Now we're going into the national linkages that are happening. And we've been working with the Journal of Canadian Dental Association to actually get input as widely as possible to the process so that all the stakeholders would feel like they're involved right up front. And also to document, we've done this, we've done this, we've done this, and actually open dialogues, right? And open them nationally and internationally. So this is John O'Keefe. He's the chief editor of the Journal of Canadian Dental Association, and he's partnering with us, his journal, to talk about social media processes. Are there innovative ways that we can now talk to dentists? How can we get the message forward? And so this is national effort that's happening at the same time. Here's the other national effort. Health Canada is our really broad national platform for health change. And we have a chief dental officer in Canada, Dr. Peter Cooney, and he's now working with us. He's producing these awareness campaigns that are now going across to the general public about the risk factors for oral cancer. People don't even know you can get oral cancer, right? So the risk factors for oral cancer, the importance of detection. One campaign went out about half a year ago, was very effective, was a pilot, and there's now a series, this is upcoming national awareness project that's going to be on HPV and oral cancer coming up in several months. And so this is important because now you see this integration of the messages that are coming both provincially and nationally and internationally. Last thing I'm going to say, and then I'll move over to the next thing. We just came from Ottawa, and the prevention program got a national award from the Canadian Dental Society. This is the professional society for oral health promotion. And the importance of this is now we're talking about edging into policy change. And to be sustainable, we have to have this transfer and ownership by the professions, that this belongs to them and that they agree. And so this is really part of the whole process of the incremental change that we need in the system to make it work. Okay, so this is not enough. It doesn't do you a great deal of good if you detect the disease, if you don't take care of business. And what we saw happening when we started the whole process is that there was these cases where patients had a dysplasia and nothing happened. 5 years later, you've got this huge, tremendous problem. It's a cancer. And we can't drop people. We actually have to make sure that that they receive the attention they need. So screening is more than an exam. It's a process. And so we're now talking about two separate things. One is surveillance. How do we make sure that patients get where they're supposed to be and that we're doing the right thing? And the second thing is, how do we make sure that the medical system is ready to receive them and that they get treated effectively and they get assessed, right? So that's what I talk about for the last bit. And it's just this whole integration of system-wide change that's really crucial. So here's the registry. This is the Canadian Partnership Against Cancer. It's working with us to create in British Columbia the template for a oral dysplasia leukoplakia registry. And it's going to allow us to collect information right across the province on the type of biopsies that dentists are taking or ENT surgeons that are taking, the pathology of those biopsies. And over time, we can then, in this registry, link to databases for treatment, find out how they're being treated. And this is really good, because this is a partnership now with the cancer registry. We can link to the cancer registry for outcome. Okay? So now we're going to be able to say, we do this kind of a change, and how did it affect what dentist practice was? What kind of pathology did we see? And what was the outcome? This is the evidence-based research we need in order to drive the process. Now, the great thing about this is we're building this registry at the same time as biopsy services in the other provinces, and so the intent is that this is now going to go national. So a year down the road, after we've sort of figured out the system, we'll have these registries going across Canada. We'll have the natural history of the disease, and it'll be linked to the cancer registry. So this is going to drive change. So that's the pathology issues. Now I'm going to talk about making sure that it's treated right, because there has to be this partnership between the screeners and the users. And so here we bring in the basic scientists, the tool builders, and they're asked to address the problems in the management of the disease. And here are the tool users, right? So we had Callum McCauley on the previous slide. We had Marshall Gilliard. We had Pierre Lane. We had a physicist, an engineer, a computer programmer, and now we've partnered them with Loie Zhang, Michelle Williams. These are people using optics and using computer systems. And the last two people, Catherine Poe and Scott Durham, who are the pathologists that are actually using the optics inside of treatment. So two things, two different questions that that we try to address by bringing these scientists into the process. First thing on the left. Okay, so we had a whole bunch of disease detected in the community. We had severe dysplasia and higher, went for treatment. Talk about the treatment in a minute. But there was what do we do with this mild dysplasia, moderate dysplasia, hyperplasia? What's the recommendation that goes back to the dentist? What do we do? Large numbers of samples. So we needed a triage point. So what we did is we asked the computer programmers to build us a system. So they went and all these things funneling down through the NIH program. We had this longitudinal study. We took patients where we had biopsies that progressed, biopsies that didn't progress, and we trained the computer systems. So now we have a system in place that's going to go into the registries where we can funnel people, same histology, but a tenfold increased risk for progression compared to the other cases. And these cases can then go forward for genomic analysis and can go into chemoprevention. So it's a filter. Okay, so important. And that's going to go across the pathologists across Canada. Other point is the treatment. So the big problem with the treatment of the disease is that it's spread across the mucosa, and it's really hard to capture the whole thing. Stuff is left behind, and you have recurrence, and the recurrence could be really high, up to 25%. And so we asked for optics for the surgeons to use to be able to see the disease better. So this is the work of Catherine Poe and Scott Durham, and I'm just going to show you a few slides. So here's fluorescent visualization. Stephen Lamb and other workers with the lung have used this for a long time to detect disease in the lung system. And now we've asked our scientists, Callum McCauley and his group, to create handheld devices that go in and they say, okay, can we see occult disease? Can we use this to help surgeons decide where to set boundaries? So here we have a cancer, carcinoma in situ. You can't see that very easy. Where do you cut? And so this handheld device shine blue light onto the surface, and we fluoresces. And you see these dark systems here? This is loss of fluorescence. The green is normal. This is the abnormal part. This is the abnormal part. If you can look back here, this is coming from here. This is carcinoma in situ. This is a severe dysplasia, right? We're seeing disease that we didn't see before, field effects. Here's another thing that the surgeon was faced. Here's a tumor, a nodule, and it's spread, right? But where do you put the margins? Here? When you look actually with the device, this is normal, the green tissue, but look at how it's spread out, and it's not uniform. And if you just put it like a 1 centimeter margin, which around tissue, which most surgeons do, you have the stuff that's left out. And what does that mean? What's left out? This is a study that was published by Catherine Pohl and Scott Durham and the rest of us here. And here's a cancer, hard to see. And the surgeon looks at this, he can mark it, he says, okay, this is the margin. But you go in with the device, you see this wide field of change. You can circle it here, take biopsies outside. Oops, these are cancer, right? And they're molecular clones. They would have been left out there. So based on this study, we had a terrific change inside of BC because our surgeons said, okay, let's take margins seriously. Let's start using this device. And they started putting their margins outside of the fluorescence area. And we followed them inside of our longitudinal trial. We saw our recurrence rates dropping from 25% to 5%. Big jump, okay? And so this has led to a project now that's just starting September 2010, a phase 3 pan-Canadian clinical trial funded by the Terry Fox Research Institute, 8 sites across Canada. It's called the COOL Surgical Trial, and it's asking the question, testing the hypothesis, FeGuided surgery will increase recurrence-free survival. So it's not only looking at cancer cases, T1, T2, but it's looking at the severe dysplasia, carcinoma in situ. And so now we have, across Canada, these patients that are funneling in from the dental network, being referred forward into clinic, and there's a consensus now and an assessment of how should the disease be managed. And out of this clinical trial, they'll become an advisory to the ENT surgeons about this is the appropriate management for the disease. So now you see all of these systems actually coming together. This is the last thing I want to say. And this is the targeted outreach that we've put in for the underserved. Not everybody can be reached through the dental network. We know that. Because the dental services in Canada are like the United States in the sense that they fall outside of the Canadian Health Act. They're not part of Medicare. So they're privately paid for. And so many people in Canada experience poor access. And so 4 out of 10 Canadians pay out of the pocket. And what you find out is that the people that are most risk for the disease haven't got access, right? So these are people like our Aboriginal communities, our rural remote communities, the elderly, immigrants, the low socioeconomic communities. So we've worked and we put targeted access points into each of these communities, and we partnered with the communities to say, okay, this is the vision, what do you need? How can we make it happen? And there's an open dialogue that's happening. So I'm going to just talk about 2, and then I'll finish. Here's one. This is the first outreach clinic that we put inside of British Columbia. It's in the downtown east side. This is the poorest locale in Canada. Medically underserved, heavy tobacco, heavy alcohol use, poverty, malnutrition, immunocompromised. And Catherine Poe has taken our devices and our whole protocols into the system, and we've looked at a needs assessment. Cancer rates are about 1 in 150 in this population, compared to 1 in 10,000 in the general population. Like, it's a huge, huge problem. And this is not including dysplasias. And so we're working now to talk, okay, what are the obstacles to care in this population, right? The broad scope care, not just detection, but management of disease. How do we do this? So it's important. So here's the other issue, and I'm coming to an end here, and that is that the global initiative of what we're doing. So in Canada, in British Columbia, we're growing mainly by immigration, and the immigration's coming from China, high tobacco use, India, highest oral cancer in the world, and our populations, we're going from 1 in 6 to 1 in 3 of the people in Canada are going to be visible ethnic minorities, right? And it's affecting our cancer patterns. And so we had, I'm going to talk about the India project first. This is Ajit Aulak. He's a dentist, oral med specialist, came from India, and we said, okay, look at our registry. What's happening in British Columbia? Our oral cancer rates are the highest among the South Asians coming into Canada, into BC. So what can we do? And so what we're doing now is we're looking at this whole limited awareness of the disease, poor utilization of the care, the different risk habits that are coming into the communities. And we're partnering with the South Asian dentists, creating a South Asian referral pathway. And they're going to be used as a bridge for us to now dialogue with India. Right? And so now we've got an open dialogue. India, tell us a little bit about the natural history of the disease. How are you handling it? And here's some devices here. Let's exchange. Let's now start retooling. Let's dialogue. And so this is a really exciting outreach that's happening internationally. And I have to say that as a sidebar to those of you in the audience, with the publication of the guidelines and the dialogue and the protocols and stuff like this, there's interest coming from the dental networks globally. I mean, we've got dialogues through Mexico, through so many different countries that want to make a difference and actually are looking for how do we partner on it. So last point. So what I presented to you is the first steps towards a population model. And it's making use of what we have and integrating all the pieces together. So it's looking at a system-wide change that's really necessary if we're going to have impact. And I wanted to emphasize to you the importance of technology, because in this case, technology linked the dental system to the medical system. That was a huge bridge that had to happen. And we had now this partnership where the disease is identified by dentists and it's actually be treated by the surgeon, right? And the surveillance system bridging it. So this is really an important facet that we have to look at. And the last thing I want to leave you with is partnership works, okay? And this is really the sustaining these collaborations means it's these one-on-one partnerships with individuals and with institutions and the sharing of the vision. So just scientists, clinicians, healthcare system administrators, and this policy makers if we're going to sustain. And we need to open this global dialogue. So, oral cancer is a global disease and it needs a global solution. So again, thank you to all the people that have participated, all the patients that have been involved, and the funding agencies, the NIH and AACR, Terry Fox, CPAC. Thanks.